Okay, good evening, everyone. I'm going to call the meeting to order. Please rise for the pledge. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay, hello. Maury, can you please take the roll?
Director Wallace.
Present.
Director Nicholson.
Present.
Director Stewart.
Present.
Director Danielson.
Present.
Director Ethan.
Present.
Thank you. Nancy, would you please introduce our guest speaker?
We're going to be prevailing on Dr. Prasad Kilaru one more time. He's our medical director for the Center for Wound Healing and Hyperbaric Medicine. And I'll remind you of his curriculum vitae, which is distinguished. He graduated from Guntur Medical College in India. He completed his general surgery residency at Bay State Medical Center, which is affiliated with Tufts University in Springfield, Massachusetts. He completed his plastic surgery residency at the University of Southern California, Los Angeles County Medical Center, and then completed a fellowship in hand surgery and microsurgery, also at the University of Southern California, Los Angeles County Medical Center. He initially practiced at the City of Hope Medical Center in Southern California for 2 years before making the move to Fremont. He started practice in Fremont in May of 2001, and since 2005 has been our medical director for the Washington Hospital Wound Care Program. He's been involved with the Washington Hospital Outpatient Wound Care since its inception in January of 2005. He's also completed an executive MBA program at Wharton School of Business. He continues to be actively involved in the new Center for Wound Healing and Hyperbaric Medicine as its medical director. With that, I'd like to hand the program over to Dr. Kilaru.
Thank you, Ms. Farber. Members of the board, I'd like to thank you. I wanted to give an update as to what's been going on at the Hyperbaric Center for the past year. As you know, we opened the new center last January, and we've had a very successful year, and I'll go over some of the numbers later on. We're currently located at 39141 Civic Center at the corner of Civic Center and Walnut. We have 2 hyperbaric oxygen chambers with the area wired for a third one, and hopefully within the next year or two we'll be able to get that going as well. We have 5 treatment rooms, 8 physicians on our panel, as well as a very highly trained ancillary staff. Just as a contrast, from 2005 to 2010, we had essentially a 1,100 square foot place that had 3 treatment rooms, a waiting room that was smaller than most bathrooms, and it was really difficult to care for the patients. And what we have now is state of the art. Everybody who comes to visit, physicians and patients, just love it. And, we have 8 physician panelists, as I mentioned. Dr. Mehigan and Dr. Safire are 2 vascular surgeons. Dr. Romano is not in the picture, but Dr. Romano and myself are the plastic surgeons. Dr. Achanta, general surgery, Dr. Asali, urology, and Dr. Patel, podiatry, are our surgical specialists, and Dr. Barish is our infectious disease specialist, who's also there. And we've been staffing the clinic 5 days a week, so we have a physician on staff all 5 days, Monday through Friday, open from 8 to 4:30 to 5, depending on our patient needs. We have a first-rate nursing staff. In fact, I'm proud to say, even before Magnet, and especially with the Magnet, we have 3 master nurses. All of our nurses are bachelors, and 5 out of the 6 nurses are certified wound therapists, which is significantly higher than what it is in most of the wound care centers across the country. We also have Paul, who's our hyperbaric oxygen certified technician, as well as a safety officer. So we've been charged with taking care of chronic wound problems in our community. And so we open our doors to pretty much any kind of wound that walks through. The most that we often see are lower extremity wounds, either related to diabetes or poor circulation. We also see our share of pressure ulcers or bed sores. We've had occasion to take care of radiation injuries, mostly after cancer treatment, as well as crush injuries, bone infections, and the like. Our newest addition to the armamentarium in the past year has been hyperbaric medicine. And hyperbaric medicine is basically a medical treatment where the entire patient is enclosed in a chamber, and the pressure in the chamber is increased to twice what is normal atmospheric pressure, and sometimes even more, but typically about twice normal atmospheric pressure. And in that chamber, the patient is breathing 100% oxygen. So they get about 10 times the normal level of oxygen in the bloodstream dissolved than what it is when somebody is breathing room air. About not all of the patients qualify or benefit from this treatment. Typically about 10 to 14% of the patients that come to the wound clinic would qualify for hyperbaric medicine. So we screen them and we make sure that they qualify. And even when they qualify, we make sure that medically they're stable to go through, because they have some risks that could potentially be problematic. If they have emphysema, COPD, things like that, we screen them to make sure that they'd be safe in the treatment. Treatment typically lasts anywhere from 2 to 2.5 hours, 5 days a week, Monday through Friday. And typical treatments are anywhere from 20 to 40 treatments. So it's about a 4 to 8 week commitment on the patient's part. And we make sure that the patient is able to make that commitment, help with rides and the like during that time. And we found that it's very effective in taking care of patients that have problem wounds. And there are many ways in which that increased oxygen helps the wounds heal. It improves the inflammatory cell metabolism, it increases collagen synthesis, it improves blood flow, it creates new blood vessels where there weren't any, and it also kills bacteria. And this effect is there not only at the time of the treatment, but lasts for up to 72 hours after the treatment, which is why we only need to do it for 2 hours in a day and not for the entire day. As I mentioned again, it's very good in healing chronic wounds. All of the indications that we dive our patients for are indications that is approved by Medicare and are what we call level 1 or level 2 data behind it, meaning there's controlled studies showing that there's been an improvement. We don't treat patients for anecdotal conditions or experimental conditions, so these are all proven therapies that we use. We also have a standardized mechanism so that regardless of who the patient is seeing, whether it's myself or Dr. Barish or Dr. Sali or Dr. Chanta, they get the same steps, so nothing is missed. It's almost through a clinical practice guidelines that we use to make sure that we capture all of the highlights and make sure that we're not missing any points for that. And we also have access to additional adjunct therapies like hyperbaric medicine, skin cultures, skin substitutes, and other more advanced therapies. Just a brief overview as far as where we started in 2005. We had 147 patients that first year. And this past year, we were well over 3,000 patients. And we look to keep increasing, and we have been increasing on a month-to-month basis. This is our hyperbaric oxygen treatment volume for last month. That initial spike that you see is patients that were backlogged that we had in the community that had not received this treatment since it wasn't available. And once we've cleared that up, we did have a little bit of a lull in October, November, and now we're kind of coming back to what we expect to be that average between 70 to 90 treatments a month. We've partnered with Diversified Clinical Practices. Now, Diversified's a wound care company, which is the largest provider of wound care in the country. And they operate several hundred different independent or mostly collaborating with hospitals, institutions across the country. And there are 3 in the Bay Area. And they've kind of helped us become what we are. They have a very good program that all of our physicians and most of our nurses have gone to that go through the algorithms, go through the hyperbaric treatment mechanism, risk benefits. It's a 40-plus hour course, very intensive, 7 a.m. to 6 p.m. each day for 5 days. And it's very evidence-based. Everything that's recommended has level 1 data behind it saying why it works and why it should be done. And it's been shown that through that practice, the outcomes are much better than benchmark. Now, this is the next slide, which is I'm most proud about. And the benchmark is Diversified's benchmark, and this is where we are. That first quarter, when we were getting all of our doctors on board, we were a little bit lower. But since then, we've been consistently better than what Diversified, which is the national standard, has been trying to tout. So we're very proud about that. Our mandate of Washington Hospital is to provide community service, and one of the things which was brought up by one of our staff physicians was to consider a wound screening program, similar to what we do with the abdominal aortic aneurysms and such. So we're doing our first wound screening program on April 28th. and we've had a pretty good response. We've had several patients sign up for it as well. There are going to be 3 physicians participating, myself, Dr. Mahegan, Dr. Achanta, and as with other screening programs, it's open to all members of the district or even outside the district, free of charge. We're basically going to give them some advice, not do wound care and treatment, but make sure that they're in the right path, and if they're not, what we can do to help them get on the right path. And my hope is that this will be successful and we'll be able to do more of these in the future. Thank you. This is again our staff, because our department doesn't work without the staff.
Dr. Killebrew, can you go back to the slide that showed the change in use over the course of the last number of years? One before that, yeah.
Yeah.
That one. Yeah, I mean, that says it all. I mean, that is.
There's also been an increase in the staff. So the first year, 2005 and most of 2006, it was just myself. Then Dr. Mahegan and Dr. Safaya came on board, and then Dr. Patel came on board. And then when we came to 2011, we had Dr. Achanta, Sali, and Barish also come on board with a much larger facility. Previously, we were only open, I think, 2 days a week. And the other days, there wasn't enough physicians to staff the place. And now, besides the 8 physicians, I have another 3 that keep asking me to join. So we're trying to find space for them, because it's a beautiful place. We have well-trained staff, so it's a pleasure to work there.
Yeah, I guess so. What do you, at the rate that you're now utilizing the facility, what capacity level are you at?
I don't know the exact numbers, but I would say we're probably around 60-70%. So we still have a little bit of ability to grow. The hyperbaric part tends to be not as constant, but our wound population has been steadily growing. And what we were looking at, as I mentioned, we still have about at least 30-40% growth available. And we have the option to put a 3rd hyperbaric chamber in.
Okay.
We have long-term my office space, which is right next door, which could always be kind of annexed if needed be. But there's enough room in the clinic to expand from 5 to even 6 or 7 treatment rooms if we need to.
Oh, great. Well, that's terrific. Okay. John?
Could you go back to the photo with the chambers themselves? And maybe for the non-clinical people, describe how the new chambers differ from the old iron lungs that were used for polio.
Well, so the old iron chambers were actually from the head down, and they provided pressure, almost like a negative pressure in patients who had polio, where you had to kind of have the machine help you breathe back and forth. Subsequent to that, the next stage were the older hyperbaric chambers, which were similar to this, but they were completely sealed. So it almost felt like you were going into a coffin, and they were completely closed off. There was no communication. There was a phone, but you couldn't really see the person that you were talking to, and you had to be able to pick up the phone and such. The newer chambers obviously are state-of-the-art at this point. They're all electronic. They also have a manual version so that if the electricity is an issue, it can be corrected. It's acrylic glass that's all the way around, so that the patient can see through. They have a couple of speakers inside, so they don't have to pick up a phone or anything like that. They can just talk, and the hyperbaric technician. So between the 2 chambers, that little space between the 2 chambers, the hyperbaric safety officers, Paul, or one of the other nurses, is always sitting here, so that either patient, if they look, they can see a person, so there's never an issue that they feel abandoned or anything. And we have TVs, DVD players, so they have some form of entertainment. Because with the 100% oxygen under pressure, it's highly flammable, so they can't take anything into the chamber. Books, magazines, none of that. So that's why we have the TV. The acrylic in the chamber is also very expensive. It's about $300,000 for the chamber. So we don't want them taking anything that can scratch the acrylic or cause any pressure leaks. So they change into our clothing that we provide. No jewelry, no bracelets, nothing that could potentially scratch the area and such.
Thank you.
Well, I know some football players get in. How about, is this any good for golfers? Or?
Well, so that's the off-label use that I was talking about.
What's it supposed to do for golf?
That's why I'm asking. Can it do any good?
I think Bubba was in one of those. So.
Yeah, he was in
Two strokes
something.
per round.
Yeah. Thank you,
Thank you.
Dr. Keller. Thank you. Okay, we're going to move on to consider the minutes of the March 14, 19, 26, and 28 meetings of last month. Can I have a motion for approval of those, please?
So moved.
Second.
Okay, all those in favor?
Aye.
Opposed? Motion passes. Any oral communications this evening? All right, Dr. Romano.
Thank you, Mr. Wallace. The credentials action items for the medical staff from March 13th are the following. First, we'd like to recommend appointments of Dr. Lily No, a pediatrician, to the provisional ambulatory service, and Vivian Tsai, cardiologist, to provisional active. Reappointments for recommendation are Bala Anadurai to medicine, active staff, Andy Chang, family medicine, active staff, Jason Cheng, radiology, active staff, Susan Xu, family medicine, active staff, Mimi Lin, radiology, active staff, Reza Malik, neuroradiology, active staff, Gabriel Miranda, family medicine, active staff, Arash Patidar, neuroradiology, active staff, Timothy Shabazian, DDS, who is an oral surgeon, to the courtesy staff, Thomas Steckel, OBGYN, to the provisional active staff, Nitin Verma, sleep medicine ambulatory, and Frederick Wilson, podiatry, to active staff. We are recommending a 60-day conditional reappointment for Dr. Moltani in neurosurgery. We are recommending extending the conditional reappointment for Joseph Rial, a physician assistant, to Dr. Kunwar in neurosurgery. And we are recommending a transfer of the staff category for Andy Cheng from active to ambulatory as requested. We are recommending discontinuing proctorship and advancing the staff category from provisional to active for both Victor Maceda in family medicine and Thomas Steckel in OBGYN. We are recommending advancement to the staff category requested, i.e. provisional ambulatory to ambulatory for Aruna Reddy in family medicine. Finally, we have 4 resignations: Bina Erasmus, Sunil Reddy, Deborah Witter, and David Vu. The gamma knife treatment criteria would be addressed later in the meeting. So we are recommending approval of those items.
Thank you, Dr. Romano. May I have a motion for approval of the credentialing action items, please?
So moved.
All those, any questions, comments? All those in favor? Aye. Opposed? Motion passes. All right, hi Sharon.
Hi.
Good evening.
Well, a short presentation from the Service League. We had a very busy month in March. Most of us were getting used to our new roles, excuse me, trying to improve the quality of the league and in turn the hospital that we serve. Shirley Crockett is our new treasurer. She was very busy right out of the gate, getting our year-end financials in order and facilitating our finance meeting. Excuse me. Fee Yu is our second VP. She was very busy with orientation, but also she facilitates our monthly information session. She and our wonderful decorating committee also facilitated our hours luncheon in March, and the luncheon was a huge success. I strongly encourage all volunteers to come to our luncheons when invited, and please bring a friend. We have a lot of fun here at the Service League. Jeannie Yee was not only busy getting used to her new roles as our first VP, but she also manages and negotiates our contract for the baby photos. Volunteers assisted with special projects this month, such as the Women's Conference, Your Kidneys, Patient Safety and Education, Medical Explorer Career Day, Stroke Awareness Day, and screening. Don't let your back pain sideline you. And I personally assisted in the Women's Conference, and I found it to be the best women's conference to date, and kudos to the staff. It was an excellent job. The Service League also rounded out this year's scholarship committee with the addition of 2 clinical staff, and will be reviewing the applications with the co-chairs in this coming month. Our first newsletter of the year went out on schedule, and hopefully everyone got a copy. If you didn't, please let me know, and I'll make sure that you get one. And lastly, the Service League Board is currently analyzing our staffing levels and we are working hard to ensure that we have optimum coverage for all of our services. And one lastly, Pat wanted me to mention that our $5 jewelry sale with Masquerade is the end of this month, April 30th, May 1st and 2nd. Thank you.
Thank you, Sharon.
Mike, that's the $5 jewelry sale.
The $5 jewelry sale. Okay.
Yes.
Unbelievable value.
It's true.
Unbelievable, yeah. Thanks, Sharon. Okay, yeah, Dr. Romano, please.
Okay, the medical staff report. We have 18 pre-applications currently in process, with 12 applications currently being processed from a variety of specialties. We had the 2 applicants that we presented this evening, and there are 4 tentatively scheduled for board action next month. No temporary privileges were processed, and at present we have 533 total members of the medical staff. 508 of those are either medical or dental professionals, and 25 are allied health. And of those, 398 are either active or provisional active. So we continue to grow.
Thank you, Dr. Romano. Any questions from anyone? Thank you. Nancy, we're going to move to the hospital calendar.
We're going to do this a little bit differently. We're going to try something new. First, we'll go ahead with Ed's construction report as normal. But Kimberly has stepped in to help me with the board calendar, which I think probably isn't as interesting as it could be for me just to be reading off a series of events. And so InHealth staff have helped her prepare a new approach to the board calendar. So after we've seen Ed's construction update, Kimberly will do that presentation, and I'll add a few extra things to it.
Super.
Ed?
Thank you, Nancy. So we're drawing down near the end here on our construction updates. So we'll give you a little bit of update in terms of the central plant. So this is the main room in the hospital where the normal power comes in from PG&E. You've seen a shot of this in the past as it was under construction. It was made operational on April 1st, and we have PG&E normal power now coming through the new plant and into the this section of the old plant, and we're functional in that regard. This is really the last thing in the central plant that's being worked on, and this is the rinse water reuse system for the laundry. And so this is going to be completed, and then as the main washers are used, the final rinse cycle of the washers gets recycled and is the first water that will be used for cleaning on the next load. So this is an energy saving capability, and that's being put together. The laundry is scheduled to be moved at the end of this month into the beginning of May, and around May 10th, the demolition of the existing laundry is included in the construction contract, and that will be the last thing that will be done. So we are moving towards wrapping things up. In the Center for Joint Replacement, again, we're in the final throes of that project as well. You can see some of the finishes going on. This is just, they're starting to clad some of the columns with the same metal that's on the exterior of the building. You can see ramps and the handrails going into place here in the garden, the exercise garden. This is just another shot of the garden from inside the building. And now this is the first floor, and you can see the finishes and the accent colors and things like that going into place. This is the second floor, so you can see the second floor is also getting pretty well completed. And this is the main office desk for Dr. Dearborn. So again, we're coming to the end of the interior finishes there. And we, again, anticipate final completion on May 15th, and to have Swinnerton completely done at that point in time. So we're still on time, obviously. The budgets for the central plant, we're going to be under budget in terms of our final number there. The CJR will be closer to being right on budget with that project. So, any questions I could answer for the board?
Man, that's a beautiful building, that's all I gotta say.
Yes,
Yeah.
it is.
Yeah, it's really good. Being on time and on budget's beautiful, but it could have been on time and on budget and have an ugly building. But it's not.
It's so exciting. I've been
Yeah.
in there with Ed, and it is really exciting to see
Yeah.
all these long-held dreams begin to come true. And I have to say that Swinnerton has really upheld their part of the bargain.
Sure.
They've done a good job. They are deserving of recognition from the board. I mean, we've had our disagreements, as you always do in a long relationship like that, where there's a lot of money involved.
No, sure.
But they have done well by this hospital.
Yeah. They're probably gonna use this in some advertising.
I would recommend them.
Yeah.
I really would. It's a lot to get something this big, this power plant and the Center for Joint Replacement done like this, and Ed and his staff have done a wonderful job as well.
Oh, sure.
There's lots of congratulations to go around,
Absolutely.
and it is beautiful, I agree.
Yeah.
You see, you can agree that this building's beautiful, but not the power plant.
Yeah, I can get next to this one. The power plant,
Okay.
I can't call a power plant building beautiful.
I can. That
Wow.
thing is a work of art.
I like the laundry, yeah.
Laundry's cool.
Yeah.
What about awesome?
Awesome,
You
yeah.
like
I like how you could take the water from the rinse cycle, use it
Yeah.
on the
Yeah.
initial cycle, right?
Right,
That's
save
what you're
water.
saying. Well, that's good. Jeez. Okay, well, thanks, Ed. Okay,
Okay, now we're going to have Kimberly introduce our new approach to the calendar.
As Nancy Farber mentioned, we decided to take a new approach, a video approach to the calendar. And I just want to thank Gisela Hernandez, who's our Director of Community Relations, Paulette, our Health Promotions Manager, and of course the staff of InHealth, who have worked to put together the beginning of this calendar by video. So, all right, Joe.
On March 17th, Washington Hospital hosted a Medical Explorer Healthcare Career Day. The Medical Explorers sponsored a career day for students from district area high schools. The day was designed to introduce juniors and seniors to the diversity of employment opportunities in healthcare. Dr. Vandana Sharma delivered the keynote on balancing family and career while working in medicine. On March 20th, Dr. Robert Miller and Dr. Jenny Maltani presented Don't Let Back Pain Sideline You, Pain Management and Physical Rehabilitation. They spoke about the common back conditions and addressed pain management, surgery, rehabilitation, and techniques to lessen back pain and discomfort. On March 24th, Washington Hospital hosted Stroke Awareness Day. Dr. Ash Jain and Dr. John Mahegan provided the results for the carotid screenings. In addition, blood pressure, atrial fibrillation, blood glucose, and cholesterol screenings were provided. Fremont Bank co-sponsored this event. On March 30th, Washington Hospital hosted its annual Doctors' Day luncheon. It was held in recognition of our physician staff and their dedication to providing high-quality medical care to our community. On March 31st, Washington Hospital held its 6th annual Women's Health Conference, Mind, Body, Energy. Dr. William Degoni Jr. provided the welcome address and an introduction to the Washington Women's Center. Dr. Victoria Leapart delivered the keynote address, Aging Gracefully. Dr. Vandana Sharma presented Can Lifestyle Changes Reduce Your Risk of Cancer? Dr. Barbara Kostick spoke on age-appropriate screenings. Makaria Meyer, registered dietitian, addressed food and mood, how one can affect the other. Karen Sindelar, exercise therapist, provided a Tai Chi demonstration. Upcoming health promotions and community outreach department events include: on April 18th from 10 a.m. to 2 p.m., Ohlone College will host its annual Spring Health Fair. Christy Caracappa with the Health Insurance Information Service will provide information on Washington Hospital programs and services. On April 18th from 11:30 a.m. to 2 p.m., Washington Hospital will host its annual Volunteer Appreciation Luncheon at the Fremont Marriott Hotel. This event will honor the Washington Hospital volunteers during National Volunteer Appreciation Week. On April 20th from 1 p.m. to 3 p.m., Dr. John Dearborn and Dr. Alexander Saw will present Aching Knees, Get Help. The physicians will discuss osteoarthritis and the latest techniques for knee replacement surgery. On April 21st, from 9 a.m. to 4 p.m., the Fremont Newark YMCA will host YMCA Healthy Kids Day. This free event will be held at Lake Elizabeth and was established to help families engage in fun, interactive, and educational opportunities to improve health and well-being. The event is co-sponsored by Washington Hospital and Washington Township Medical Foundation. Also on April 21st, from 11 a.m. to 3 p.m., Washington Hospital's Green Team, the City of Fremont, and other local Tri-City organizations will present Let's Go Green Together. This free Earth Day Education Expo will raise environmental awareness and share eco-friendly ideas with people in our district. Attendees are encouraged to learn about recycling and how to save energy. On April 23rd from 6 p.m. to 8 p.m., Sergeant Greg Crandall and Sergeant Jim Kopp of the Fremont Police Department will present Digital Safety, Cyberbullying. The officers will instruct parents on how to recognize the warning signs of cyberbullying. They will engage teens through real stories, demonstrating the long-lasting negative consequences of this damaging behavior. On April 24th, from 12:30 p.m. to 2 p.m., Dr. Diane Martin will present Learn the Facts About Shingles. Dr. Martin will discuss the increased risk of developing shingles for those who have had chickenpox and are over the age of 50. She will speak about how to recognize the symptoms and how to reduce risk for developing the condition. This event is co-sponsored by Washington Senior Care. On April 28th, from 10 a.m. to noon, the Washington Center for Wound Healing and Hyperbaric Medicine will offer free wound screenings. Physicians and staff will perform assessments on non-healing wounds and determine if treatment by hyperbaric medicine will work. On May 1st, from 1 p.m. to 3 p.m., Ellen Kuzo, RN, certified hospice and palliative nurse, will explore why quality of life matters are important. She will discuss how changes in a person's life as the individual matures impact decisions made about lifestyle and healthcare plans. Attendees will learn about an advance directive and PULST, Physicians' Orders for Life-Sustaining Treatment Forms. This event is co-sponsored by Washington Senior Care. On May 1st, from 6 p.m. to 8 p.m., as part of the Stroke Education Series, Dr. Ash Jain and Doug Van Houten, RN, Stroke Program Coordinator, will present on stroke prevention and other disease processes and healthy lifestyle. Be smart and avoid stroke. On May 3rd, from 7 p.m. to 8 p.m., as part of the Diabetes Matters program, Kevin Bronson Castaigne, RN, will present. He will discuss the latest diabetes treatment options and practical ways to manage the condition in Research Advancing Diabetes Management. On May 7th, from 7:30 a.m. to 4:30 p.m., the hospital will hold its annual Employee Health and Safety Fair. The event is an opportunity to motivate and inspire employee health and safety. On May 10th, from 12 noon to 1 p.m. in the Washington Women's Center, Dr. Stacy Berry will present minimally invasive treatments for gynecological issues. She will explore the latest developments in surgical treatment options for gynecological problems. Also on May 10th, from 7 p.m. to 8:30 p.m., Washington Hospital will host the 3rd annual Celebration of Life event. Cancer survivors and their loved ones are invited to an inspirational evening with a panel of speakers and a dessert reception. Attendees will hear how the panel's cancer diagnosis has allowed them to grow and find renewed strength and zest for life. The American Cancer Society is co-sponsoring this event. Washington Hospital Healthcare Foundation. On Tuesday, March 27th, the Washington Hospital Healthcare Foundation held a reception for the Center for Joint Replacement at the La Rinconada Country Club in Los Gatos. The reception brought together 65 attendees who heard about the future of the program from co-medical directors Dr. John Dearborn and Dr. Alexander Saw. Ed Fayen presented on the new facility for the program. The Washington Hospital Healthcare Foundation is pleased to announce that this year's golf tournament will be held on Monday, June 25th at Black Hawk Country Club in Danville. Proceeds from the event will benefit cancer services and hospice care at Washington Hospital. For reservations and sponsorship information, please call the foundation at 510-791-3428. Washington on Wheels Mobile Health Clinic. During the month of March, Washington on Wheels Mobile Health Clinic continued to serve community members at the following locations. The WOW Clinic also provided healthcare service to students at these schools. In addition, WOW provided free hearing and vision screenings for the Fremont Unified School District State Preschool Program. Internet marketing. Washington Hospital Healthcare System's website remains very active. The website had almost 32,000 visits. Some of the links most visited include the Employment and Physician Finder section. InHealth Channel 78. Washington Hospital's InHealth station aired a new Inside Washington Hospital show featuring the Washington Township Center for Sleep Disorders. Other shows that premiered on Channel 78 include several health and wellness lectures. WIA. The Washington Hospital Employees Association conducted an American Red Cross blood drive on March 29th. There were 29 registered donors and 25 units of blood donated. WIA accepted applications from graduating high school seniors who are dependents of Washington Hospital employees for the Hospital Employee Scholarship Program. Applications were accepted through March 29th.
Well, thank
What
you,
do you
Nancy. That
think?
was very well done.
Wow.
It's a little bit easier than listening to me.
Well, but the visuals were nice too.
Yeah,
It's
they
very
were.
nice. Yeah, very nicely done.
I've asked that they make the print in black so that you can read it more easily. If you're visually challenged like me, watching that on television, you might not be able to read everything. But other than that, I think they did a great job.
Oh, absolutely.
They brought a calendar to
There were a few things that didn't get in there, and, as we do this, we'll get better at it. I wanted to mention that George Markhouse did hold a donor appreciation event on March 18th. They have a very beautiful donor wall, and each donor is recognized with a painting of a rose. And we're now a major donor at George Markhouse, and the Washington Hospital name went up on their wall on that day. I also wanted to mention that work is progressing with the rescue for St. Rose. We are nearing agreement with Alameda County Board of Supervisors on the JPA. We hope to have that within the next few days, and we believe that the Board of Supervisors will vote on April 17th. The Health Committee will be on the 16th. The supervisors as a whole would vote on the 17th. Then that JPA will return to this board for action. Because the board won't vote in time for your Monday evening scheduled closed session on Monday, the following Wednesday, I'm going to ask the board to convert to open session and entertain this matter then so that we can do this quickly and move on to developing the definitive agreement between the JPA and St. Rose so that we can move this along. Our PricewaterhouseCoopers audit process is ongoing. There haven't been any showstoppers yet. I believe that if they found something tremendously wrong, they would come and tell us right away. And so far, it's proceeding. I think they'll be at work at least 2 to 3 more weeks. And everybody at St. Rose is cooperating with them, so this is going as planned. Cal Mortgage came down to visit St. Rose last week, and we attended the meeting. And basically, they had arranged for an extension in the line of credit. And they wanted to talk to the interim management at St. Rose about how that was going to be spent. It was, I think, a highly satisfactory meeting. Cal Mortgage left satisfied that the interim management team was doing their job and doing it well, and we're going to be careful with that money. So I think that went exceptionally well, too. So far, so good. I also wanted to make mention of the activities in the community that the board members participated in during this past month, and that didn't get into the calendar. On March 15th, Dr. Jacob Epen attended the Journey Home Breakfast for the Abode Homeless Services. On the 15th, we also had Pat Danielson and Dr. Epen and Dr. Bernard Stewart attend the Newark Chamber of Commerce meeting where Congressman Mike Honda was introduced at lunch. As you might recall, we've had redistricting, and now Mike Honda represents a portion of Washington Township. And so we'll be making friends with our new legislator. On March 23rd, the Indo-American Community Federation held its Unity Dinner. Pat Danielson and Dr. Bernard Stewart attended on behalf of the hospital. On the 29th of March, the Alameda County Special Districts Association held their annual dinner. That was attended by Pat Danielson. On March 30th, the Fremont Chamber held the State of the City Luncheon, and that was attended by Pat Danielson, Dr. Epen, and Dr. Bernard Stewart. The board's been busy and out in the community. And finally, it's my privilege to announce that we had a first at Washington Hospital. Our own Dr. Ash Jain performed a first of its kind angioplasty procedure in this country for peripheral arterial disease using a drug-eluting balloon instead of a stent. This balloon has demonstrated significant reductions in the recurrence of blocked artery compared to the more common procedure of using a stent. Additionally, the new procedure allows patients with peripheral artery disease to undergo treatment without having a foreign object, the stent, being left in the body. And that occurred here on Monday. First in the country. The employee of the month is Edwin Sampson. Edwin was hired as a nursing assistant in January of 2005. He was trained to become a dialysis technician. He received his certification as a dialysis technician in July of 2007, and at that time he transferred to our dialysis department. He continues to demonstrate great enthusiasm for the field of dialysis patient care. He's taken extra courses as he's gone along to help him better understand this area of nursing practice. And because of his continued growth in this area, he was promoted to the position of senior dialysis technician in July of 2009. He has successfully passed the BLS instructor certification class, and he helps the nursing education department in the recertification of nurses. Along with his wife, Charlene Masengay Sampson, staff nurse 3 on the 4th floor, they are proud parents of 2 daughters. And when not on duty, Edwin's busy supporting his daughter's dancing classes. He's an avid bike rider and is involved in an upcoming race for diabetes.
Well, thank you, Nancy. Any questions or comments? Okay, we're going to now move to the quality report to Stephanie Williams.
Thank you, Mr. Waters. Tonight I'm going to be showcasing the Intensivist Program. An intensivist are physicians that are specially trained in critical care medicine. They have to be board certified, and oftentimes they have more than one certification. So our intensivist program started in 2007. We now have 5 full-time board certified intensivists, 5 part-timers. Dr. Carmen Akawili is our medical director, and she is the one that really championed this program. And if you ever in ICU, she's always in there. You cannot miss her. She's there all the time. She believes in the multidisciplinary team approach, which means it's not just the physicians, it's everybody that make up the team. We had 24/7 coverage since July 2009. We have an open and concurrent model, which means the intensivists as well as the primary care physicians can care for patients in the intensive care unit. And this is a safety net for the primary care physicians because the intensivists are there 24/7. They're very involved with consultation and coordination of care. And oftentimes this is very seamless from the patient standpoint. They are always there. They are the experts. They work closely with the primary care physician. But from the patient standpoint, it is virtually seamless. They have a very good referral rate in terms of 50 to 75% of the physicians refer their patients to the intensivist. So let's talk a little bit about the program objectives. First and foremost is to promote patient safety and quality of care, to identify and improve condition of deteriorating patients, provide appropriate, reliable, and timely care using evidence-based therapy and best practice. And the guidelines that are used by the intensivists come from the Society of Critical Care Medicine, and that's the gold standard in terms of providing care to the critically ill. Create a highly effective multidisciplinary team headed by an intensivist. And by the multidisciplinary team, she's talking about nurses, she's talking about physical therapy, respiratory therapists, infectious disease. Everybody comes together to be part of the team. And last but not least is to integrate patient and family into the care received, which means we want the patient at the center, patient-centered care. Looking at the initiatives for 2011, because this is the annual report, one of the programs that they have implemented, and it's a pilot project, and it's going to be going house-wide in terms of the critical care fairly soon, is the delirium program. And delirium is a condition that can be very short-term. It starts from a few hours, it can extend to a few days. And this is where the patients have some difficulties in terms of their memory impairment. They can be disoriented. They can at times be unable to focus. It's not that they're not truly at their capacity. And now the focus throughout the country is to identify those patients early and intervene as quickly as possible. Because when you do intervene, you have less mortality, you have shorter length of stay, and you have better outcomes for those patients. So that is the goal, and it's a project throughout the country. The palliative care project is looking at the patient wishes and making sure their wishes are being adhered to. This is involved in terms of the patient's healthcare decisions, and that is involved with the patient and family as well. The family assistance program, again, is patient-focused, family-focused, is looking at things that can bring in the family as part of the team, making them part of what we do in critical care, getting them involved, looking at the communication, looking to see what resources they need, what are some of the things that we can do better in terms of getting them involved. And they're working on protocols, delirium protocol, as I mentioned earlier, revising the insulin and critical care drips, and the sepsis order sets. And you know, we are one that has been a champion in terms of the sepsis program. We were early adopter, one of the earliest adopters in the Bay Area for sepsis. Let's talk a little bit of accomplishments, and there are many. First and foremost, the multidisciplinary grand rounds. Every year there's a critical care month, and I think it runs between, I think it's May and June. And we get the best speakers from around the country to come and give talks, and it's open to all employees. Physician, nurses, anyone that wanted to attend can attend. They have looked at giving classes in terms of ultrasonography, diagnostic ultrasound at the bedside. I think that's a new technique that's coming out, and we have a doctor, Dr. Sweeney, he's one of the intensivists, and he's the one that was able to bring the program to Washington hospitals, and we had staff and ED physicians attend. We had in-service lectures about delirium and early mobility, and these were from renowned speakers around the country. And we continue to do community lectures in terms of decision end-of-life care that was done in March 2011, and the sepsis awareness that was done in 2011 as well. In terms of team building, the multidisciplinary rounds, as I have mentioned earlier, it's where daily rounds are done in critical care that talks about the plan of care for that patient. Is the patient meeting their goals? And this is where you have the pharmacist, you have the nutritionist, you have respiratory therapists, you have the physical therapist, you have the intensivist, and we also have the primary care physicians at times making rounds and looking to see what are the patient's needs, are their needs being met, and what else can we do differently to improve the patient care. We have done a lot of work around ventilators in terms of reducing the length of time the patient stays on the ventilator. We have done really well in terms of that, and you will see that data later on. Early mobility, you have already heard in the past in terms of getting those patients out of bed as quickly as possible. And infection control, they have begun the infection control rounds in the ICU. It's done by the infectious disease physician, Dr. Diane Martin, and that's a part of what's being done in the ICU. The family assistance program continues to evolve in terms of feedback from the family and the patients as well. And if you are in the ICU or in the hospital, take a look around outside of the ICU. There are many bulletin boards out there that talks about what's being done in ICU as well as some of the accomplishments that have been done. Looking at it from a quality standpoint, we have used the simulation lab to look at communication strategies and scenarios. There's a critical care class that's offered for physicians on a yearly basis. We have also used it for family care conference guidelines in terms of making sure we know how we are interacting with the patients and making sure it's truly beneficial to the patient and the family. Improving palliative care, as we talked about the patient wishes. And by the way, April 16th is National Healthcare Decision Day. So this is where you want to have your family, your friends, and your healthcare provider know what your future healthcare wishes are. Improving ventilator hours, we discussed that earlier, and you will see some data associated with that. And that has been presented at other areas outside of the hospital. And improving deep vein thrombosis, which is blood clot. They receive a grant from the American College of Chest Physicians, and it's to look at better management and interventions of VTE, because that's still the #1 problem out there in terms of complications for patients that are often in bed for a long period of time and post-operatively as well. They have done presentations. The ventilator outcomes was presented at Beacon 2011, and we had an intensivist, we had a respiratory therapist, and we had an RN. All did a presentation. We were in Beijing in October of 2011. We were the only community-based hospital that attended the conference. And to boot, we got our abstract in one of the magazines. That was unheard of for a community hospital. And again, this is championed by Dr. Halimi and also Dr. Carmen Aquilili in terms of being a team. Looking at results, this is what I was talking about in terms of the ventilator, reducing the length of time the patient is on the machine to help them with their breathing. And we have done really well since the implementation of the Intensivist Program. So 2008 was early when the intensivists took over, and you see from time to time we have really gone down, and in many instances we are better than the national benchmark. Looking at some of the results, look at the VAP. This is incorporated into the care we provide on a daily basis. And we have gone 749 days without the incidence of VAP. And that is a lot of teamwork going in there in terms of the physicians, in terms of the nurses, the respiratory therapists, working together as a team. When you look at the ICU mortality rate at Washington Hospital compared to the California Hospital, we are at 11.4%. We are better than the other California hospitals. When you look at nosocomial MRSA infections at Washington Hospital, we had 0, whereas the goal and standard out there is getting to 0, but it was 0.08 at a time. And blood glucose level, we know that when you have a high blood glucose level, you have more chances of getting infections and you have a greater rate of complications. And the intensivists and they are working to make sure that the patients in critical care have a blood sugar that's within normal limits for their condition. Looking at the next steps, what do they have in store for the next year? They're beginning to look at blood transfusion strategies. Right now, there is a group that's meeting to look at blood transfusions. The national guidelines regarding blood transfusions have changed. So we are taking that into consideration, and we are looking at best practice in terms of the reduction of blood transfusion. Nutritional assessment in the ICU, as you have heard before, it's very important. It helps with the healing process. So now that's going to be another project working to make sure that we look at the nutritional status of the patient in ICU. We're going to develop a bundle for delirium that we were using on the patients that were on a ventilator that's going to be spread house-wide throughout the intensive care units. For Nursing Initiative, they are part of the team as well. And nursing control their practice at the bedside. Pressure ulcer prevention is nurses' own. There's no any which way you look at it, it belongs to nursing. There is a group that's looking at that as well to make sure that the patients in critical care do not have pressure ulcers. They are looking at central line bloodstream infection to make sure their risk of infections are extremely low, almost non-existent. The glucose control monitoring, again, is a multidisciplinary team looking at that to make sure that we are monitoring the patient's blood sugar. And catheter-associated infection, which is urinary tract infections, we're looking to make sure that we're following guidelines, and if those catheters do not need to be in there, in the patients, we take them out. All this leads to better patient care and improve outcome. In terms of education, they're going to continue to use the SIM lab for communication strategies for physicians. They're going to continue to do in-service education and multidisciplinary grand rounds. This is coming in May again, and the critical care support courses. And again, we're going to be working with the community in terms of the education of sepsis. We're beginning to work with the nursing home, with the clinics, and we are taking the sepsis program on the road. As far as the palliative care program, again, this is going to be a work in progress. We're going to continue to work with that. The family assistance program, they're working on a brochure for intensive care as it relates particularly to the ICU. The transfer team guidelines in terms that regardless of who's caring for that patient, the handoff is the same. So handoff is extremely important to the intensivist. And the family and patient guidelines. We need to give the patient some guidelines in terms of some of the questions that they have given us in terms of feedback. We're going to begin to incorporate that in terms of how we provide care. Any questions?
Questions, anyone? Thank you, Stephanie. Very good report. Thank you.
Thank you.
Okay, Nancy, we're going to move to the finance report.
Yes, we'll have
Chris?
Chris Henry make that presentation.
Pardon me?
Chris Henry will make that
Oh,
presentation.
yes. Indeed.
Okay, so good evening. Tonight we'll be walking through the operational and financial results for February 2012. And we'll jump right into our acute inpatient statistics. Average daily census for February was 7.8 above budget at 205.1. We had 1,116 admissions, 41 above the budget of 1,075. And our patient days were 227 above the budget at 5,948. Our average length of stay for the month based on discharges was 5.1. We had projected 5.32 in the budget, so the length of stay was a bit shorter. Case mix index for the month came in at 1.446, which is higher than we've seen it for the last several months. We expected 1.462 in the budget, so it was pretty close to what we had expected. We had 7 more deliveries in February than we expected at 169. And surgical cases beat the budget in the month. We had 18 more surgical cases at 362. We had budgeted for 344. Those include the joint replacement cases, which were 5 above budget at 106, and our neurosurgical cases were 3 above budget at 21. Cardiac surgical cases were 5 below the budget at 9. And our PTCA procedures for the month were 14 below budget at 53. Outpatient visits for February were 118 above the budget at 8,626. And our emergency room continued its frenetic pace with 4,440 visits in February, 242 above what we expected in the budget. Looking at productivity, in February we saw 1,453, almost 1,454 full-time productive FTEs in the month. Non-productive FTEs for February came in at 161.8, so we end the month with total FTEs 48.7 below budget at 1,615.7. Our full-time equivalents per adjusted occupied bed, which is our productivity measure, came in 0.36 below budget at 6.23. So management was flexing staff pretty well. Moving into the financials, as always, we'll look at our Governmental Accounting Standards Board presentation first. This is the presentation used for our audited financials. Patient revenue for February came in almost $7.6 million above budget at $171,804,000. Our contractual write-offs for the month were a little bit above what we expected at $74.65, leaving us with net operating revenue almost $1.3 million above budget at $44,492,000. Operating expenses for February came in a little over $1.3 million above budget at $42,423,000. And the big driver here, as we've seen the last several months, is our health and welfare costs. And it's really a function of an increase in total claims, the total number of visits. This isn't an increase in cost per visit, but right now our health and welfare claims are running about 16% above what we saw in the same period last year. So that's a real driver for the month and the year to date. So we end the month with an operating bottom line from a Governmental Accounting Standards Board point of view, about $52,000 below the budget at $2,069,000. Non-operating income for the month came in $847,000 below the budget at $369,000, largely driven by an unrealized loss in our investments of almost $1.6 million. So we end the month with a total bottom line from a GASB perspective about almost $900,000 below budget at $2,348,000, but a good improvement over what we've seen the last several months. Moving into the Financial Accounting Standards Board presentation, and for those not familiar with this, this is the way Wall Street tends to look at us. Operating bottom line stays the same at $2,069,000. We pull out our general obligation bond revenue and our unrealized loss on investments to come up with non-operating income from a FASB perspective, $684,000 above the budget at $1,243,000. And a total bottom line, $632,000 above the budget from a FASB perspective at $3,312,000. So any questions on February results?
Questions? Nice looking month. Yeah. Thank you. Thank you, Chris.
Sure.
You ready
Nancy?
for March?
Yes.
Okay. The month of March saw the admission of 1,127 patients that resulted in 5,923 days of care. Our average daily census in March was 191. This was lower than February's of 2005. The high and low census ranged from 199 down to 163. The budget for March anticipated 1,165 admissions and 6,224 days of care, and an average daily census of 201. So we're going to be about 301 patient days of care below the budget for the month. The average length of stay for adults and children in March was slightly higher than budgeted at 5.39. The budget anticipated an average length of 5.34 days. Our preliminary information indicates that the inpatient revenue for the month of March amounted to approximately $136,442,000, compared to a budget estimate of $139,299,000. Of this amount, 54.3% was Medicare, and only 6.4% was Medi-Cal, and we're finding that number somewhat strange. So we're backtracking on it, and I will report to the board further on that. We usually run at about 9 to 11%. The 6% Medi-Cal figure was somewhat unusual. Birthing Center saw 153 deliveries in March. They had budgeted 174. Newborns totaled 154 this month. Surgery had some very interesting results. The general surgeons were busier than they've been in a long, long time. Normally we see about 50 to 60 cases in general surgery. They had 134 in March. It's the best month of the year for the operating room. It was largely a result of heavy emergency room volume. Our joints replacements cases were off by 10. Our cardiac surgery program missed their budget by only one case, so they were higher than usual. Vascular surgery cases were down by 11. Our surgery minutes, actual time in the OR, came in on budget. So they had a total of 418 surgical cases, which was a very big month for them. 587 cases were seen in the outpatient surgery center versus a budget of 599, so they were pretty close to budget as well. For the month of March, there were 400 cases seen in the cath lab, including 50 PTCAs. Our total cath lab cases were lower than budget by 85, and I would make a note that 2 weeks out of the month, Dr. Ash Jane was out of town. And I think that largely accounts for that bit of a slump. Our non-emergency outpatient visits for the month of March came in at 9,731. They were below the budget of 9,945. The emergency room recorded a total of 4,592 patients, a daily average of 148. This is the highest volume in that ER since 1996. Washington, Warm Springs, Newark, Nakamura, Ohlone, and Walmart clinics saw approximately 4,439 patients during March. So our total system emergency room and clinic visits for March are at 9,031 compared to a budget of 10,164. Full-time equivalents for the month of March totaled 1,605.7. This included 36.92 agency personnel. This was lower than the budget. The FTEs per adjusted occupied bed came in at 6.52, which is slightly below what we had budgeted at 6.54, pretty close. In summary, we had 38 fewer admissions and 301 fewer patient days than anticipated in the budget. The surgical cases were below budget by 6. The cath lab procedures were below budget by 85. Outpatient visits for March were 214 below budget, while the ER visits were 127 higher than anticipated. Total paid FTEs are below budget by 81.5 for the month, and the FTEs per adjusted occupied bed were below the budget. Inpatient charges for the month were lower than budgeted by approximately 2.1%, or $2,857,000. Our outpatient charges were also lower than budget by 0.03%, so pretty close to budget. Total hospital charges will come in under budget by about 1.6%. Again, getting close. On March 31st, there were 152 days cash on hand. The total days revenue and accounts receivable at March 31st was 67.21. Excluding Medi-Cal, they came in at 59.52. During the month of March, $69,176 of charges were approved or pending charity assistance.
Thank you, Nancy. Any questions? Okay, we are now going to move to the action items this evening. Dr. Epen?
Mr. President, I move for the approval of the Medical Staff Department of Radiology Gamma Knife Treatment Planning Privileges Recommendations. These were reviewed by the Joint Conference Committee.
Okay, we have a second. Any comments or questions? All those in favor?
Aye.
Opposed? Motion passes. Item B, please.
Mr. President, I move for the adoption of resolution number 1116, which is the memorandum of understanding between the Chief Executive Officer of the Washington Township Healthcare District, the recognized representatives of the Board of Directors, and SEIU UHW West, effective July 1st, 2011, in accordance with the resolution number 331A as amended.
Okay, we have a second. Any questions, comments?
I think that I should mention that the contract, key financial items include a 3% lump sum payment on July 1st of 2011, a 1.5 across-the-board payment for July 2012, January 1st of 2013, a 1.5 across-the-board payment, July 1st of 2013, a 1.5 across-the-board payment, and January 1st, 2014, a 1.5. These are lump sums and not a geometric progression. The contract was negotiated with no reopeners. This covers 502 of our employees here at the hospital. The contract further clarifies the duty of bed clerks so that they can continue to ensure the continuity of care for our patients. It allows greater flexibility in staffing as it allows for a cross-training opportunity for these union members. The lump sum agreement in the first year makes it possible to adequately compensate our employees, yet also remain in budget for the future years. And the agreement also clarified the grievance process so that we can have fewer grievances and work in a collaborative manner if and when there are areas of mutual concern. I'd like to thank SEIU for their collaboration in this negotiation.
Thank you. Okay, all those in favor?
Aye.
Opposed? Motion passes. Item C.
Mr. President, in accordance with the district law, policies, and procedures, I move the Chief Executive Officer be authorized to proceed with the purchase of 37 flat-screen digital televisions for 6 West for a total amount not to exceed $36,693. This upgrade was included in the fiscal year 2012 capital project budget.
These are for the patient rooms.
Yeah, for the patient rooms. And if only our hospital equipment would decline in price like these have, it would be really good.
It would be really nice.
Yeah. Okay. All those in favor? Aye.
Aye.
Opposed? Motion passes. Any more items for consideration tonight?
The closed session.
Yes, we will. Adjourn to a closed session. Thank you all. Welcome back, everyone. We're going to reconvene the open session and announce that no actions were taken during the closed session. Is there any other business for the meeting tonight? Seeing none, this meeting is adjourned. Thank you.